found, Dr. Wang? And she was saying 200 variants. Is that like for Cohen syndrome?
You mean Dr. Klein, what does she probably refer the 207 gene for retinal pigmentosa? Is that what you refer to, Lisa?
Well, I didn't know if she was saying, and Morgan is coming in, okay. Is just, I wasn't sure if she was saying there were 200, and maybe you can explain, is that 200?
There's 200. I was just saying there's over 260 genes that are associated with various inherited retinal degeneration.
Oh,
So
gotcha, okay.
Cohen
Gotcha.
specifically, but just all of these different, so,
Okay,
things that
perfect.
might look like RP would actually be, something else. So lots of different,
Okay.
these panels have lots of, they cover a lot of ground. So very helpful.
Okay. Yes, this is Morgan must want pretzels. All right, go out with your daddy. All right, great. All right, oh, and Q&A came up. Oh, nope, I think that's another one. Hey, families out there, you guys have some more questions? Yeah, because it's like 12 o'clock. I don't know if we want to do like a little bit of, let me see if other people bring some questions up. Or
Since
we can,
the Dr. He is still here, maybe. So I want to just reflect what her research, how relevant to the Cohen syndrome.
oh, that would be great.
Yeah, and I think we had a lot of discussion for two things we feel important. One of the things in this conference, the parents actually already knew because at least half of our children on the Neupogen injection for neutropenia. But what I knew, 10, 15 years ago, the first question I asked, I knew that the next speaker about this, so we're looking forward to hear. But the 10, 15 years ago, we actually, my question was, after Neupogen injection, neutropenia is corrected. And do the children have normal immunity against infection, or do they still have quite a bit of infection? After the neutropenia is normalized. So what we found is actually in our children, a lot of children, and the parents here can talk too, is after the neutropenia is corrected, normalized. And the children still, they're doing much better for sure, but they still have a lot of infection. So that tells us, that the neutropenia, the number is problem, but it's not the whole story. And then the cell function, neutrophil function to fighting infection may be still a problem. So that is actually reason we pick up this the direction, because the Dr. study actually to really study the function, neutrophil function relate to the, her areas, the research area. So this glycotation CGD, Cohen syndrome, if relate to the function, if it is, then it probably could potentially treatable with some supplements or the we saw in other disease. So that's one of the reasons we pick up this the topic to move forward. And then I think we make some progress. Other things more relevant to this study is any study, just like a doctor say, if we do the natural history, why the natural history study is important. So if we do the gene therapy, do any medication clinical trial, our clinic currently doing 6 clinical trial, not in the Cohen, in other conditions. But what we know is any condition, if we do the clinical trial, we do the gene therapy, we have to, just like Dr. say, have some baseline. Who we compare with, are they doing better with gene therapy? We have to compare with people who do not receive the gene therapy or medication, which is a natural history, naturally disease. So if for those children receive gene therapy, they are clearly doing better compared to this group who no receive gene therapy. then we know gene therapy is working. So that's why before we started any gene therapy, anything, and then we have to build up the natural history. And then the third one, the study, what she's doing is find the biomarker. So what does that mean, biomarker? You actually can measure the blood or something is measurable and then associated with the disease directly. So reflect the severity of the disease. So when you give certain treatment, medication, or gene therapy, that biomarker is normalized. So we know the marker is become normal. So we know it's working. So these are 2 or 3 important components when we move forward. That's why, I mean, that's actually what she's doing is identify biomarker, and then how clinic is doing more natural history study, and then to find an intervention, something we could use to improve the children's health immediately. So that's what I'll focus on. Yeah.
No, thank you for kind of explaining and simplifying it a little bit. So it's really trying to, I guess, further understand it to kind of have the building block of, so that way when gene therapies are available or treatments, that, really knowing what needs to be done. Because it's so interesting with our kids, how they're so different. They're the same, but they're different.
Yes.
Like where, as far as
Yeah,
how affected.
you are exactly right. So the what we trying to do is score. For instance, the constant children, some of them verbal, some are not verbal. And then we score 0 for no verbal, score 1 verbal, and then score 2, they can talk in sentence, for example. And then similarly mobile, the developmentally, if they walk, they are not walking, or they are walking, or they are running, and then we base that, give the score. Then we use that score to see how correlate to the blood sample we send to Dr. Hurd. Is that a relation? Anything we can find to reflect the severity of the disease. And then when we see that, if we see the score improve, and we also see the biomarker improve, then we know it's working. Yeah, does that make sense?
It does. And what I've noticed, Dr. Wong, too, is like you can have, and because of the different variants, and I feel very fortunate, kind of like we're starting with the association, I've met a lot of our kids. So I feel like I have a pretty good knowledge of the different, as far as just behavioral, and what I've observed is like interesting, where like Morgan is nonverbal, but she doesn't feature some of the autistic tendencies, where I've seen some other kids that are verbal, but then maybe they might be verbal, but then they have autistic tendencies, but then you have other verbal kids that don't. It's just, I think it's going to be very interesting when you guys correlate what the scoring, because you almost have to subset it based on also if the child, on what their behaviors are. I guess as many data sets as you can. I think it's going to be a pretty big database.
Dr. Wong, I have a question, and it's a genetic question. I'm sorry, a hematology question, but it's more of a Cohen syndrome question. And it's a big topic in conversation on the page. Do you believe that they all carry a gene for neutropenia? It just doesn't present itself at certain times at their ages, or are there some that will never present and never carry the gene for neutropenia?
Yes, the COH1 gene, which is VPS13B, and then actually part of the disease, neutropenia is part of the disease. They carry, everyone carry that. I do believe with almost 100% of all the children with Cohen syndrome, they more or less on the low side for the neutropenia. Yeah.
Are you familiar with the pill that they're trying to trial now for, instead of Neupogen, that they're trying to trial a pill?
I'm not very familiar. Hopefully the next speaker will tell us about it.
Yeah, I don't know if they're aware of it, but it would be interesting. I'd rather give my daughter a pill than a shot every day.
Yeah. Thank you for the question.
Right. Oh, here, you know what? There's some questions here. And I know also later this afternoon, because I know like Ashley with what they're doing, her foundation, she's going to be kind of talking about the research that they're doing. Looks like from Erica, could you share with us about medical care after childhood into adult medical care for our kids? It's very hard for us to get a medical doctor. And I know this firsthand. I mean, I think a lot of us as our kids get older, what are we going to do? You know, we're just finding some, you know, it's a whole bunch of stuff. So I don't know if that's as far as
Yeah,
the
it
medical-
is. I mean, it is challenging. I agree 100%. You know, this is one of the topic American Academy of Pediatrics trying to address is a transition of the care from pediatric to adult care. And then in general, it's hard, and for the children with special needs, it's harder. And then for the children with Cohen syndrome, even harder because it's so rare. You know, for that particular issue, our clinic, what we do is we enable you know, hire the adult the internal medicine you know, physician. And then Dr. Cruz actually a couple of years ago, you guys probably saw him, and he's trained internal medicine. He actually started facing already to make sure continuity of the care, and also to beyond the childhood. So I think that the two or three things that probably we could suggest. One is find the potential, you know, internal medicine or family doctor ahead of time, you know, before the transition, before they reach to a certain age, and then that would be helpful. Usually, family doctor, they can see both pediatric and adult, but the internal medicine they can only see adult. But if that's internal medicine doctor you plan to pick as primary care physician, it would be a good idea to start thinking before a certain age, you know, different stage, you know, like 18, 21, you know, and then in reality, most pediatricians, they are willing to actually taking care, you know, for a few more years beyond their pediatric age. And they know the children well, they feel comfortable taking care of them. And then until you find the doctor, as primary care physician. And then of course, there's the other hematologist, ophthalmology, you know, beyond certain age, that's also transition. Sometimes even harder to find the doctor. But when you cannot find someone, I'm sure the physician who currently taking care of those children, they are willing to take continue provide care until you find somebody you're happy with. Yeah.
I can just add to that. Based on experience, we make sure that we're connected to a hospital in our area that's both pediatric and adult, because typically what will happen is that pediatric doctors in that hospital will end up flowing over to see Michaela, God forbid, if that's the case, in the adult environment. So we try not to just go to an adult hospital.
Yeah, it looks like there's, and someone's asking about IgG. Does this translate to raised or lowered IgG in the blood? That
Mio, are you currently online? Mio? Oh, here it is. Yeah, she's online.
Yes, I am. I haven't measured IgG levels from the glycosylation pattern I see. So there are two possibilities. One is you have a higher level of IgG, which probably I would say 50% of chance you may have higher level of IgG in Cohen syndrome, but more likely is the glycosylation on IgG has been altered. So that's a more likely correlation from the glycosylation changes I see. The reason I said that is because this particular glycosylation change that we see very enriched in Cohen syndrome. I also see it in other patient that has a defect in cytokine signaling. So from that group of patient, I know that glycosylation can dramatically change. That has nothing to do with IgG level, but has associated with the cytokine signaling. Basically say you have same level of IgG, but the function of IgG is very different. Does that answer your question?
Thank you, Mel. Lisa, you're muted.
Thank you. My earbuds died. I had to do plug-in, sorry. Yeah, there's 1, 2, and I think these are just genes. There's genes anonymous. Are you aware of ABC4? There's a couple different ones, because I know there's a lot of different mutations. I don't know, our next speaker, let's see, argument IgG times. Sorry, I'm trying to clear the chat. Are you guys aware of those other mutations? I know there's a lot of mutations for Cohen syndrome. So I'm, like.
Yeah, I'm reading that question that in reality, when you go on with genetic testing, the current time, currently the people test, pretty much all the gene on the list. So besides the findings on the VSP, the 13, the Cohen COH1 gene, and then you will see that the other we often call the incidental finding. If it is a cause disease, but mostly when you report it, they tell you this is more like a carrier. So a lot of time, you talk with the genetic counselor, most of them the finding is actually carrier. Just like we all carry certain disease is harmless, to be a carrier. So you that's partly what I'm assuming. That's partly showing that in your genetic testing report.
All right, any other questions? I don't know. So we may want to, I think the next.
I have a question.
Oh, sure, Diane.
This IAG biotics research, is that something that, I have the bottle here, is that something that you would recommend?
What is that? I'm not very familiar with.
Okay. It's actually large, LARICINA isolate. Large, LARCHLARICINA isolate.
I'll be more than happy to do some research. This is something I'm not very familiar with. Yeah.
Okay.
Yeah, you send an email. I'll be glad to do some research for you. Yeah.
Okay. It was recommended for Alan to take as a supplement. So that's why I was curious. Thank you.
All right, if we, one more time for questions, because maybe we may want to take like a little break. And then come, because I know the next speaker, and certainly everyone's welcome to hang on, but maybe, I don't know if anybody's holding back kids or anything, and like do a break until the next speaker. And I can just kind of monitor things. Let me see what's on chat.